I'm Toni Chan, consultant rheumatologist at the Royal Berkshire Hospital in Reading. It takes 8.5 years for axial spondyloarthritis currently to be diagnosed. Our aim at the NAS is to reduce this to 1 year. In order to do this, we will need to be able to detect much earlier the symptoms of axial spondyloarthritis and lead us to making the diagnosis. The prevalence of axial spondyloarthritis is 1 in 200 in the population. In patients attending clinic with chronic back pain, 1 in 20 of these patients will most likely have axial spondyloarthritis. Often it is mixed up with possible mechanical back pain. However, we should be careful in taking a history to elicit any features of inflammatory back pain. In the presence of inflammatory back pain, we should also be looking out for any other clinical features such as inflammatory bowel disease, uveitis, enthesitis, and psoriasis. Even when these clinical features are present, especially with also a family history of spondyloarthritis, then it will be very worthwhile investigating this further. And the tests that can be useful include HLA-B27, inflammatory markers such as CRP, and also X-ray of the sacroiliac joints. The important thing to note here is that axial spondyloarthritis has an equal prevalence between male and female. It is no longer thought of as male-only or male-predominant disease. Secondly, the HLA-B27 may be negative and the CRP may be normal. The X-rays may also be normal in the early stages of disease. However, if the clinical suspicion remains high that the patient has axial spondyloarthritis, we would recommend doing an MRI scan of the whole spine and sacroiliac joint, ensuring that we detect any inflammatory changes that are seen. It is very useful here to collaborate and also to work closely with your radiologist in order for these changes that can be seen on the MRI to be detected earlier. Axial spondyloarthritis remains a clinical diagnosis. In the presence of supporting investigations and clinical features, one can make a diagnosis of axial spondyloarthritis. However, there are also classification criteria such as the ASAS classification criteria that can be useful in order to standardize the comparison between patients, especially in clinical trials when we are looking at efficacy of treatment, to ensure that these patients meet the classification criteria. Why are we so keen to reduce the delays to diagnosis? Because there are very effective treatments for patients with axial spondyloarthritis. If we can detect these patients earlier, they can access treatment earlier, which will lead to better outcome for the conditions and also reduction in long-term morbidity and mortality. So we are really excited about this prospect of reducing delays to diagnosis, and it's vital that we work together as a community to change the narrative of this condition. It's also important that we work closely with other specialties such as radiology, dermatology, ophthalmology, gastroenterology, and also with our community partners such as primary care and also physiotherapists and first contact practitioners. Together, we think that we will be able to meet this challenge to reduce delays to diagnosis, and that will be the gold standard that we all aim for. Thank you.